This is the first meeting of our series. The second one was together with Dr. Barron. The third one with three distinguished colleagues. The fourth one, again, with two senior educators. The fifth one, together with Dr. Rachel Jenkins. Today is this one. I'm going to try to tell a few things about our speakers. Dr. Rodrigo Ramalho is from New Zealand, but originally he is from Paraguay. He will be talking on health beyond the hospital, mental health promotion and public health. He is a psychiatrist, as I said, originally from Paraguay, but currently living and working in New Zealand. He teaches in the Master of Health Practice and the Master of Health Leadership at the University of Auckland. He supports medical students as an advisor for their medical elective and during the Population Health Intensive Week, which is the topic of his presentation. Eugene Ko is from Malaysia. He will be talking on technology adaptation education. He is a psychiatrist and medical lecturer of University Putra, Malaysia, ACT practitioner. He has sports psychiatry interest, involved with teaching psychiatry undergraduate and postgraduate, and professional development focusing on resilience in undergraduate medical students. Cenan Hepturgun is a psychiatrist from Turkey, a lecturer at Ege University. Main area of interest is developing web-based psychoeducation applications, supervises residents and teaches undergraduate students about management of the agitated patient, co-chair of a team that organizes events to share good educational practices. Dr. Francisca Bessler is going to talk about psychomatics for medical students, what keeps people away from cancer prevention, treatment, and psychosocial counseling offers, which is an educational research project funded by the Stroop Foundation. She is a psychiatrist and psychotherapist from Heidelberg University Clinic, Germany, supervisor specializing in psychosomatics, research working group leader on education and communication, co-founder elective for medical education, digital medicine at Heidelberg University. She is interested in research in medical curriculum development for medical students, teaching psychosomatics about delirium, editor on a book for medical students on standards for good patient-doctor communication, more than 100 lessons, workshops on innovative teaching for medical students, such as educational games using standardized patient, for example, to train on vaccination lessons in psycho-oncology. Dr. Mariana Pinto da Costa will be talking on volunteering in mental health. This terrible starting is not the only thing which I missed. I have missed the document about Mariana's brief CV. She's from Portugal and she's now in UK. And I hope she will say a few words about herself at the beginning of her speech. And we have three discussants, Ramin, Joyce, and Sevde. Ramin is a medical student from Malaysia, Joyce from New Zealand, and Sevde from Turkey. This is for the time being. I think I will have to stop sharing. Dear followers, I'm very sorry for the terrible start, but anyway, I believe our speakers will cover up my mistakes. May we start with Rodrigo? Let's hear your presentation, please.
Thank you. Let me just... But first of all, to say thank you very much, Bulent, for the invitation and for organizing this whole presentation. I know you are beating yourself down now a little bit unnecessarily because, yeah, thank you very much for putting this all together. So thanks. And like Dr. Koskun mentioned, I am currently working in New Zealand in the University of Auckland here in Auckland. And what I want to share with you in just a little time is something we do here at the university, which is called the Population Health Intensive Week. And which I think it's a good representation of this, of introducing students to a different way of thinking about health and healthcare and what is involved in healthcare beyond the hospital, focused particularly on health promotion and public health. So the Population Health Intensive Week is an activity that sixth-year students from the medical program at the University of Auckland have to do. It lasts, as the name suggests, 1 week. It starts on a Monday and it finishes on a Friday. The students are divided into teams and they are allocated a topic, a facilitator, some community agencies that they need to visit. They're also provided with a fictional 500,000 New Zealand dollars. And the goal of the week is for them to prepare a public health campaign. So at the end of the week, they need to present the campaign that they prepared to peers and review and panel. So I want to talk a little bit about how that week goes. But first of all, to mention that there is a wide variety of topics that are allocated to the different groups. And some of them cover mental health issues and addiction issues and other important public health issues here in New Zealand as well. So in preparation for the week, the university first contacts potential facilitators. These are subject experts on one of those topics, part of the teaching or the research staff. They volunteer their time to help during the week, meeting with the students and facilitating their progress throughout the week. In preparation for the week, there are a couple of workshops where facilitators are invited and the week is presented to them, timetables, expectations, and people who already have experience with the week can provide newcomers with some recommendations and tips for how to ensure students' success during the week. Something else that the university also does in preparation is get in touch with community agencies that are in one way or another, but mainly from a public health perspective, addressing those issues that I showed before. And students are allocated around 6 community agencies, 6 to 8 community agencies that they need to visit. These are governmental and non-governmental organizations, advisory groups, research teams, and there is a person there in the community agency who also volunteers to welcome our students and to answer their questions. And with the advice of both facilitators and community agencies, the university collects a series of readings and reports that are all put together into a Canvas page and a student handbook. So on Monday, when the students come to the university for this week, they are granted access to the Canvas page and their students' handbook. So they'll know for the first time who are the other members of their team, what are their topic, which is their topic, the community agencies that they need to visit, and who is their facilitator. They're also introduced to the timetable of the week and the expectations, and they attend a series of morning presentations and panel discussions. So at the end of the day, that Monday, they meet with their facilitators who further helps them to organize the week to make sure that they do what they need to do by Friday. It is very intensive. There's a lot of work, and some of these students may not have worked together as a team before. So that meeting with the facilitator and themselves as a group is an important part of the week as well. So on Tuesday, that Monday, like I said, they go to some presentations during the morning, and these presentations are focused on introducing students to public health thinking. They need to think upstream. In case you're not familiar with the analogy, the idea is of comparing healthcare service with someone being downstream a river and pulling people out of the river as they come along. But thinking public health means thinking upstream, and walking up the river and seeing if there is a fence broken up there that can be fixed and would prevent people from falling into the river. Thinking about social determinants of health, and thus the socio-ecological model of health, thinking in terms of systems, not so much about how individual things have their individual impact on the overall health and well-being of the population, but rather how they working as a system are creating an environment with which people interact and where they make their decisions and perform their health behaviors. Thinking about equality and equity, and being a bicultural country as New Zealand is, students are also further reminded of the Treaty of Waitangi and a Maori health framework, which is the Te Whare Tapawha, which is a holistic model of health that covers all physical, psychological, spiritual, and social aspects of health. Students are also introduced to the Ottawa Charter, which is from the WHO, and it's a guideline for how to think health promotion. So not so much top-down intervening, but rather ground-up empowering interventions that create the necessary changes for these interventions to be sustainable in time and empowering of the community. Because, as you might be very familiar with, there is this saying of health being not just the absence of disease or illness, but also a state of well-being. But the phrase is incomplete without the last part, which is health is also being in control of the things that have an impact over your health and well-being. And following this model of health promotion is about that. It's about helping people to gain or regain control over the things that have an impact over their health, creating supportive environments, strengthening community action, reorienting health services so that they are responsive to the community's needs and preferences, and a series of other potential actions. So on Tuesday, after being introduced to this way of thinking public health, on Tuesday and Wednesday, students go and meet with their community agencies, and they do some research about the topic, reading the literature that they were allocated. They need to start thinking about their campaign as well. They need to start discussing potential ideas with the community as they visit them and thinking about budget and things like that. So on Thursday, which is the day before the week ends, they need to have finished developing their campaign, prepare a presentation that they need to do on that Friday, and finish a written report. The written report needs to provide the rationale and the justification for the strategy with evidence that support their likely success and the impact of their strategy. This report is submitted on that Thursday night, and it's a night of heavy reading because a group of people read all reports, making sure if that there are no gross things or huge things that would need to be addressed before the presentation the next day. So some of the recommendations that the students are given when thinking about their health campaign is, what is the evidence of the impact of the topic and the evidence behind the potential success of your strategy? What is currently being done, and how is it that your strategy will connect with things that already exist in the community, including policies? How will it connect with the community agencies that you have talked to? Are there any challenges preventing people from improving their health in that particular topic that you were allocated? And how can we diminish these challenges? How can we diminish these barriers, making it easier for people to achieve health win, making it easier for people to have control over the things that have an impact over their health? Your campaign, basically, the idea is for students, for their campaign, basically, to be something that would trigger a change or create an impact that will be sustainable in time and that will be linked with the systems, creating the problem, diminishing then this problem, or the systems currently in place trying to address the issue, making it easier for them to succeed. So on Friday, they make an oral presentation to peers and a reviewing panel, and key issues are discussed, and they are provided a pass and non-pass mark. And sometimes the community agencies that were visited attend this presentation, and I can also say that sometimes some of the strategies that were prepared by the students actually became adopted by some of these community agencies. So basically, this whole week is about promoting, introducing and promoting students to think upstream, not to think only about the causes of things, but also about the causes of causes. Thinking about groups, not only just about individuals, but also how groups are affected by these issues. To think prevention, health promotion, and protection. To think about inequalities and inequities. It is not enough to think about inequalities and making sure that people have a similar access to resources, but to think also about the fact that there are communities that have more profound needs for historical, socioeconomic, and cultural factors that they might need some extra support to make things equitable. To think about environments, the environments in which people act their lives and have their daily routines, and to think about the systems and the policies put in place that creates these environments with which people interact and live their daily lives. So basically, yes, that's the Population Health Intensive Week. And if you have any question about it, or you would like to have access to these slides, please send me an email and I'm happy to have a talk or share them with you. Thanks.
Thank you very much. It's indeed a very interesting and, as you say, an intense program. And the most important part, I think, is the sustainability and fitting to the existing system. What I believe, this video recording will be, in a sense, a book-like, textbook-like information gathering from different parts of the world. And now, may we go to Eugene to listen to his presentation, please.
All right. Thank you very much. Let me just turn on my presentation. I'm going to present a bit slightly different. I'm just going to talk a bit about something that we adapted since the pandemic started, and I do think that we have some potential in this. What I'm going to talk about is how my department or how my unit kind of actually adapted existing technology to kind of deliver psychiatry education slightly different. We actually set up this plan way before the pandemic. I wrote a few proposals in 2019, and we saw a lot of potential in it. What happened was the pandemic hit and we couldn't actually move on with the project. But seeing potential in it, I kind of adapted it and used it during the pandemic. And I'm pretty much, let's see how we go. So what I did was that traditionally when we do about video recording, when we talk about clinical skills sharing, this is the classical picture we will see. We will see a head and shoulder, two side-by-side kind of presentation. Or another presentation would be you will see both ends. At this, you see two people talking at the side, you might be able to see the full one. It does have some of its limitations. If we were to use the first one, you only see the upper body in terms of how they actually chat and get the history. And if you were to use the full body, the eyes kind of get distracted. It's kind of, we're not sure where to focus kind of thing. So when the pandemic hit, all our teaching actually went online. All our teaching was transferred to online. Universities were closed for physical teaching. And we have to kind of quickly adapt to that situation. How are we going to continue our usual clinical teaching in a sustainable way, in a useful way, where the students will be able to learn from the patients similar to how we would traditionally do in a face-to-face. How can they observe it? How can they have that same experience? As I pointed out, if we have traditional video recordings as such, it's actually a bit different. So what I'm going to do is I'm going to show you a different video here. I'm not going to share sound. I'm just going to show you the implications of what we could do. So what we did was we've done this recording across multiple sessions. We've discovered that if you use a camera that has 360 view, it allows us the freedom to kind of move around during playback. So this is something that I'm doing now as I'm talking. I'm actually moving this as I play. As they play, as they go about, I could actually move the screen and I could highlight to the student, okay, let's look at this. Imagine this is a patient, look at the hands, look at how anxious he is. I can kind of focus and play in real time to tell them, look at the body posture, look at the language use. Now look at the clinicians when they interview, see how it's leaned forward, how is they able to convey compassion, and so on and so forth. So what we essentially did was we adapted the existing technology and oops, I accidentally shut down my slides. Sorry about that. I'm just going to proceed without that. So what we essentially did is we adapted existing technology into use during the pandemic. Our original plan was to build out a whole library of recorded videos that we could use, that students could use on their own later during offline teaching or on their own kind of schedule. The technology, it's already there, but it hasn't been utilized in a lot of medical fields, especially in psychiatry. So we kind of believe that it has a lot of potentials. Another unexpected utility for it is actually, if I could just open that. Another unexpected utility for that is actually when we discovered that this camera has a webcam function. What we're doing now is that I actually use the same camera inside my actual clinical settings. So the students might not be able to move around the camera like I showed just now, but they are able to see in like this split screen view that I'm showing on screen now. So students are able to watch two things now. Despite being at home observing me, they're able to watch how I ask questions, how my body language, how my intonation, how am I going to display some of the non-verbal cues. And at the same time, the students are also able to watch non-verbal cues, the interactions of the patient at the same time simultaneously. Essentially, this is mimicking a clinical kind of observation where they traditionally would stand behind us, stand by us and watch the interview. But that camera itself allowed the delivery of this kind of education in a slightly different manner. I believe there are much more different potentials with regards to using this kind of technology. Some of the other potentials is that this camera actually allows us to take a 360 photo of an environment. So imagine if I go to a patient's house or somewhere where they work and we could able to take a photo of how they look. Students will be able to experience that. They are able to explore that kind of environment from their home without actually having to be there. It will kind of supplement some of the teaching limitations that we are actually facing now during the pandemic, where they're not allowed to come to universities, or they're not able to go to the patient's house safely, or they are not able to experience a lot of the things. It is a tool that we use to kind of overcome it. I do think it's high potential, but it would require a lot more exploration. And as we speak, we're just trying to see if we can find more new ways. Essentially, we took hold of existing technology, adapt it to the limitations that the pandemic brought upon us, and hopefully, as this develops in the future, we're not sure where it will go, but hopefully it will be more beneficial for the students in terms of the education. With that, I end my presentation today.
Thank you very much, indeed, Eugene. It's interesting that you also use the same approach, seeing all the detail, adapting existing technology, similar to what Rodrigo has said. And now I'm not working actively, but during my practice, I used video so much. And I wish I had your technology to capture the body language, both in the interviewer and the person who is being interviewed. This is indeed a very important approach. Thank you very much for that. Now, may we go to, I'm trying to keep the questions to the end. May I go to Cenan for his presentation, please?
Thank you. Let me share my slides. Hello. First, I would like to thank you, Professor Coşkun. I'm very excited too. And this is really a privilege for me to be a part of this meeting and to be here among invaluable speakers and discussants. I am a psychiatrist and a lecturer at Ege University, Izmir, Turkey. I will try to talk about helping medical students with their approach to the psychiatric patient, and I will give a brief explanation of the educational system in Turkey in a couple of minutes. We live in Izmir. Izmir is in the west side of Turkey. It's a beautiful city at the seaside. You can see it's in the Eugene region of our country. This is the entrance of our hospital in Bornova. Ege University is a huge hospital. It is the biggest in the Aegean region with a bed capacity around 2,000 patients. And at the right bottom corner, you can see our psychiatry clinic. At this right building, we have rooms for our inpatients, and we have a capacity for around 60 inpatients. But since the beginning of the pandemic, we run in the half of our capacity, which is about 30 patients. Against, it's in the left in this building, we have our other rooms like classrooms, library, laboratory, and faculty members' room, etc. At the center, we have a large closed garden. This allows all of our patients, they can spend time here freely during the day and get some fresh air whenever they like. Let me introduce you the medical education in Turkey. In Turkey, education in medical school takes 6 years. The first 3 years are preclinical years, while the second half of the 6 years are clinical years. The third year is a kind of bridge between preclinical education and clinical education. Students encounter theoretical knowledge about behavioral sciences and psychiatric diseases for the first time in the in the third year of their medical education. After the third year, starting from the fourth year, during the clinical years, first they take a 2-week psychiatry course. Depending on the faculty, this course may be on the 4th grade or 5th grade. And there are also theoretical lessons in this 2-week course. Students, but this time also they meet with patients, but they do not have patients for whom they are directly responsible. But, they only have the opportunity to watch psychiatric interviews and observe the patients. But in the 6th grade, the last year, once again, students come to our clinic for their internships, this time for a month. This time, they have patients for whom they are directly responsible. We want them to master their patient's history, examination, and treatment. We also want them to interview with their patients every day and be aware of their current status. They also find chance to observe a large number of patient interviews, which are held in the outpatient clinic. Also, during this internship for 1 month, they have 2 or 3 emergency duties, which can also observe. They can also observe the approach to the psychiatric emergencies. Of course, psychiatry education has multi-dimensions, but considering that we have a limited time here, I will only speak about a couple of words about communicating with patients. In my experience, I have seen that medical students usually have some concerns about communicating with psychiatric patients. For example, they ask, is there anything I should be careful about when talking to patients? This is a very common question the students often ask to us. Of course, it's very polite that this thoughtful student does not want to say something wrong that will have a negative effect on the patient. But on the other hand, I think this question might be somewhat related to stigmatization. Students might be putting psychiatric diseases in their minds in separate place from all other diseases, from all other clinical branches. For example, I don't think as students, I don't think that they ask the same question when they go to the infectious diseases rotation. Is there anything that I must be careful about when I'm talking to patients? I think they don't ask this in that rotation. There they have no doubt that a respectful and polite manner will be sufficient when talking to patients, as well as a medical knowledge. But in psychiatry, they have this concern. And these concerns in physicians' minds make them leave the duty of talking to psychiatric patients only to psychiatrists. So This causes problems for psychiatric patients, especially when they seek non-psychiatric medical help, because it's difficult to take an ideal history and perform an examination when you are not sure how to communicate with the patient. In my opinion, one of the most important achievements about medical students during their 1.5 month duty in our psychiatric clinic should be the prevention of this stigma. We should ensure that all physicians feel very comfortable in all settings with communicating with their patients, with their psychiatric patients. Of course, this can be possible only by interviewing as many patients as possible, and also by watching the interviews of psychiatrists. This is a part of our library in our clinic. We also call it here the mirror room, because the mirror you see here is one-sided, while there is a psychiatric interview going on this side of the mirror, the students, and we watch the interview live from behind the mirror. After about 45 minutes of interview is completed, we come together again, we discuss the interview, not only the diagnosis and the treatment of the patient, but also the interview and the process between the patient and the doctor. We ask students to share how they felt during the interview. Also, we ask how the interviewing physician might have felt, or how the patient might have felt during that interview. We talk about the patient's medical illnesses. We ask our students, what if you meet this patient in another settings, or another medical disease, or another complaint? How should the patient be approached when seeking for help for the other diseases? What can be done to make the patient feel more comfortable while describing his or her chief complaints, for example? Due to security reasons during the pandemic, we could not perform this interview live, because many people need to come together in a small area behind this mirror. So for this reason, we recorded the interviews and started to discuss with small groups where we could sit at a safe distance from each other. Of course, after obtaining informed consent from our patients and taking all precautions regarding privacy and security. At the end, I would like to repeat that in this limited time reserved for psychiatry during medical education, one of our most important goals should be to enable physicians to communicate comfortably with psychiatric patients in any setting. Thank you. This is all I want to say. Thank you.
Many thanks, Cenan. I understand you have given a general overview of the medical education in Ege University and also in Turkey in general. And maybe other friends from different areas during the discussion could share if there are some differences with what they practice in their own settings. Now, due to the time problem, I will go to Franziska Bessler. But before that, I should have mentioned that this sixth meeting of the Association for Community Mental Health Promotion is in collaboration with World Psychiatric Association's section on medicine, psychiatry, and primary care section. So this is the first implementation of this collaboration. Now, Franziska, may we listen to you, please?
Sure, it's my pleasure. Thank you very much, Bulent, for having us here today, and I'm very glad to see all my friends here around. So, fitting from what you just said, our topic now is psychosomatics for medical students, what keeps people away from cancer prevention, treatment, and psychosocial counseling offers. So this is an educational research project that is funded by the Struble Foundation, and you can find additional information, also extra information for patients on www.struble-stiftung.de. Well, once reminding us about the importance of cancer. So cancer is the second leading cause of death just after cardiovascular diseases. And we have to know that between 30 and 50% of cancers are preventable. And unfortunately, cancer screening services are used very disappointingly low, and there is a gender gap. So men consult doctors and healthcare services less often than women, and they die earlier, up to 5 years, and they use psychosocial counseling offers less frequently due to healthcare notions, habits, and decisions influenced by gender socialization processes. If you want to find more information about that, you can also have a look at a video we have provided on the website down here that's giving some extra information on that topic. So, but the question is, what keeps people away from cancer prevention, treatment, and psychosocial counseling offers? And therefore, we do an educational research project. It's still open to participate, so you can do that by using this link if you want to. And looking at the results so far, we found that one of the main problems is poor awareness. Some people report it's just difficult to get an appointment, and some just really don't like to think about cancer. And something that's really striking out just from the beginning on is that we are all thinking about this gender gap, and we can see it right if we check the data that our ratio so far, like who is actually filling out this questionnaire, is that it's more than 80% females. So the question is really how to address, how to educate, and how to get our male colleagues motivated at this point. If you look into the literature, once again, you can see that there are indeed issues such as poor cancer awareness, referral issues, financial barriers, logistical barriers, psychosocial barriers. People claim long waiting lists and talk about suboptimal resources. And particularly for men, because we are aware of the problem they do have, is that there might be really a problem in regards to their masculinity beliefs. They like to be tough, they like to be self-reliant. So how to incorporate it in medical education, this very big problem? Well, once again, what is psychosomatic medicine? And I can quote a publication. I have publication I've written is, so it was originally attributed to Mr. Heinroth in 1818, and it's recognized under different names such as biopsychosocial, integrative, holistic, or patient-oriented medicine, and most recently also as consultation liaison psychiatry. It's an interdisciplinary field, and it provides an integrative view on health and disease. And it studies psychosocial factors, basically, on the vulnerability and outcome of a medical disease and the integration of psychological and psychiatric therapies into the treatment of the medical disease. And there's something very outstanding we have in the medical educational system here in Germany. So here in Germany, psychosomatic medicine is an independent specialty outside from psychiatry and outside from and outside internal medicine. It basically focuses a lot on psycho-oncology, and that's the link actually to oncology. But it also means that we have a medical curriculum only about psychosomatic medicine for our undergrad students, and also as a specialist on top of that. So I'd like to give you a short, just some best practice examples how medical students are taught in our psychosomatic department. Well, we believe that medical students are our agents of change. So if you really want to change something in the community, it's about educating our future doctors and they will spread this attitude to all their patients for the upcoming 20, 30, 40, maybe even more years of professional life. So you really have to make them aware. So as I said earlier, the awareness problem not only starts with educating patients, but basically making medical students aware about the issues. And how can you actually address that? So we have found in different studies that it is very important to be interactive with your medical students. So make sure they're really aware when you talk to them. Don't talk to them, listen to them and exchange your point of views. Make them interactive. For instance, do role plays. Something also I think Eugene is keen on is educational games, such as quizzes and so on. So you can actually like play quizzes or let them play quizzes about the topic you think that are important. Something that's also really helpful is the usage of a standardized patient. And we also introduce standardized families. So you're basically observing a family. For instance, we have a role play where we have a toddler and the family, and we talk about vaccination issues with them and their psychological problems of all going on in the pandemic. So you do role play with the different parts of the family. So it becomes really natural feeling when you do those training with them. Keep in mind that particularly video consultation training has been very important in the last couple of months. So we have been training about also the technical aspects and problems when you conduct your teaching online. Something really also helpful is the usage of micro-teaching. For instance, if you break bad news, so people can actually see themselves, how they look like, how they speak, how they interact. They can get peer feedback. And sometimes it's actually very helpful for them to see how they are perceived by their peers, and they might change their behavior just afterwards. Also, we know from educating patients is that if you can find a local network, for instance, of cancer patients who are willing to share their psychological issues, it's a very big impact on the medical students if they remember patients for the first patient they have talked to for the rest of their life. It's a really big thing. As I said, interaction is important, and making sure your medical students are in contact with the patients. And last but not least, I know most medical students don't like to hear that, but it's true, unfortunately, assessment drives learning. So if you really want your students to get into the topic, sometimes it's really helpful, maybe even formative, but not only summative assessments. So they will concentrate on the topics that are important for their professional lives. Having said that, thank you to my team, Alisa, for helping with that, my mentors who might be listening or not to this, and Bulland, of course, who's doing an amazing job bringing us all together and being so passionate about it. My colleagues, of course, my patients, my students, and last but not least, the Struve Foundation. It's important for us researchers to have foundations caring about educational research for the good sake of our patients. Thank you very much.
We thank you as well a lot, Fran. Thank you for sharing all these interesting points, underlining all these interesting points. Could you please stop sharing? Maybe, Fran, could you stop sharing?
Oh, sorry, it says I already did, but...
All right. Of course, the last point you made was interesting. You said the students don't like, but they are not the only portion who don't like being assessed, I think. But I'm afraid it's still, you're sharing your video. your screen. Franziska?
On my screen it says I stopped, but I'm trying different options to change that.
Now it's okay. Okay, thank you. And of course, maybe during the discussion we can come to the point of how to assess, because that's a very important part of the training, education and all. Thank you for your presentation. And before coming to Mariana, I would like to, with her help, cover my point which I missed about Mariana at the beginning. She's a consultant psychiatrist at South London and Moseley National Health System Foundation Trust and a senior lecturer at the Institute of Psychiatry, Psychology and Neuroscience, King's College, London, United Kingdom, and also the Institute of Biomedical Sciences, Abel Salazar, University of Porto, Portugal. She teaches psychiatry to medical students at King's College, London in the UK, and at the University of Porto in Portugal. Please, may we hear you, Mariana?
Thank you so much, Professor Boland, for the kind introduction. And thank you so much for organizing this important event about medical education. So first of all, I'd like to ask if you can see my screen. Yeah, all good, good. So the project that I'm going to speak about involved a number of medical students, but actually it's a wider project that involved a number of people in the community. And it was assessing volunteering in mental health and exploring the impact that that had in people with mental disorders, but also in those that volunteered to provide support. And some of the people who volunteered to provide support were indeed medical students. So if I can move to the next slide. Yeah, okay, good. So first of all, I'd like to start, those of you who are here hearing today, if you have seen a friend in the last week. As this is being shared in YouTube, I'm afraid I can't ask you to raise your hands, but I want to ask you to think about that, if you have seen a friend in the last week. Now, moving to my second question, I'd like to ask those of you who have a smartphone, if you can please also think about that. Yeah, so imagine that most of the people that are here today either were in contact with a friend in the last week, and these days that we're using technology more and more, that you personally have a smartphone. The reality in terms of people with mental illness, we know that more than half of patients with psychosis, unfortunately, had not seen a friend in the last week. And we know that many patients are extremely socially isolated, which is, of course, one major problem. But we also know that people with psychosis are increasingly more owning technology, which is good and helpful and a potential resource to support people who are isolated. So people with psychosis, sorry, I just got a bit missed, but yeah, moving on to the next slide. So people with psychosis are often experience social isolation. As you can see in this slide, this is either linked with their own condition, so sometimes having feelings of withdrawal and decreased social function linked with their clinical condition, but unfortunately also due to the stigma and discrimination by the general population. And also there has been research showing that in health staff and also in mental health professionals, there is indeed stigma towards people with severe mental illness. And we also know from research that actually social isolation is linked with worse health outcomes, both in terms of physical health and mental health, with patients reporting more psychiatric symptoms and being more likely to be re-hospitalized. Now, there are a number of potential resources that can be used to address the situation. And one of them is volunteering, which has been promoted to tackle social isolation and support recovery. However, many expect in-person meetings, so face-to-face meetings, requiring a greater effort of availability and commitment. There is therefore a need for more flexible, easily accessible support. And we have seen with the pandemic, with many countries that had very strict lockdowns and social distancing measures, many of the interventions in the community had to be shifted from face-to-face to remotely. And this happened not only within healthcare, but also with medical education, with many classes and teaching sessions moving on to become remote. So now what I'm saying is that there is potential for bringing together people in the community, including medical students, and from an early start of one's career to have an advocacy role and a social community role in a different way, as Rodrigo mentioned, but addressing the same aim, which is supporting the community and the mental health population in a particular place. So using technology to bring people together. Now, what I'm going to tell you about was actually done within a research project. So this was like a mixed method study that explored the views of a number of key stakeholders on volunteering mental health, which led to the development of a new model of support. And just to give you a broad overview of what this research entailed, so it started with focus groups with mental health professionals and volunteers in 3 countries. And then I conducted a survey with patients in London with a sample of 151 people with psychosis. And further to these initial views gathered, then in an iterative process with input from a PPI group. So this stands for Patient and Public Involvement. And this group was named Sugar, as you can see here in the picture, and a national volunteers organization in the UK, which is named Befriending Network. A new intervention came to light, which was tested twice, initially only in London and later on throughout the whole country. So you can see here in the slide the summary of what this intervention entailed. And this aimed to connect patients and volunteers remotely through a smartphone. And the aim was to tackle social isolation and to overcome physical barriers and distances. And patients were matched with a volunteer in the community, and many of whom were medical students, and they could speak for a period of 12 weeks through audio calls, video calls, text messages, WhatsApp messages, and emails. And we offered all participants a smartphone and monitored their communication and step count. Now, for those of you who have had already some knowledge or read something about how to go about developing an intervention, and in this case, like a psychosocial intervention, they normally have like a logic model, which means that one looks at the context in place and what would be the mechanisms of change of potential intervention and what we're trying to change. So as you can see in this figure, the logic model of the intervention is focused on the contextual factors of the patients, such as social isolation, but also on the smartphones, which are widely used, and the availability of volunteers to support patients. And the mechanisms of change of the intervention were engagement, role model, and self-efficacy, which were thought to have impact on different outcomes on both patients, but also on volunteers, also on those who were medical students and were volunteering for this project. So I'm going to share with you actually the findings that we had at the end of this project and some of the characteristics of our sample. So first of all, the demographics of our 36 participants, they varied. Most patients were men and most volunteers were female. The mean age for patients was 41 and volunteers were a bit younger, with their age ranging from 20, which were primarily those that were either medical students or psychology students, but we also had volunteers that were 67 years old, and these were some people that were already retired and suddenly had more free time in their lives and they wanted to take part in this project. Most patients were Asian or Black, and most volunteers were white. Nationality-wise, interestingly, most patients were British, whereas most volunteers were immigrants. And most of the patients were unemployed, with most volunteers being employed or retired. And finally, most patients lived alone, whereas most volunteers lived with their partner or family. Now, when comparing the outcomes of this intervention at the beginning and at the end of this project, we found some benefits in the patient's quality of life, self-esteem, number of social contacts, and improvements in the symptomatology, but we found a decrease in their physical activity and in the social comparison. So this means the way that they perceive themselves in comparison to others. Whereas for volunteers, we found benefits actually in all parameters. For example, like quality of life, self-esteem, physical activity, but also social comparison. So how they perceive themselves in comparison to others. And also, we also were measuring one of the features that was particularly assessed in volunteers, which was attitudes towards people with mental illness. And we found improvements with a reduce of social distance in how volunteers perceive people with mental illness. So this shows that as an intervention, it was helpful for volunteers to improve and address the stigma that the volunteers had initially with this intervention. So many of these volunteers before, they did not have any contact at all in their life with a person with mental illness. So sometimes there are these myths about mental illness or concerns. And by being exposed to a person with psychosis for a period of 12 weeks remotely, and by speaking with each other and sharing their daily lives and routines and what they wanted to share with each other, it changed the perceptions and the views of the volunteers, including of those who were medical students, on how they perceive people with mental illness. So there is a potential of using this intervention actually to address stigma. So you have here like an example, as I mentioned, this was a mixed method study. So we looked at quantitative measures, so a number of scales that were validated, and I just briefly share the outcomes. But we also conducted one-to-one individual interviews at the end of the study with all patients and all volunteers. And I've just selected for this presentation 2 quotes, one from a patient and one from the volunteer. So you can see that this patient said, "I'm glad with this experience. It told me a lot. It told me to be confident. It told me that I don't have to be scared, that I can make friends again. It was quite easy, speak with someone over the phone, get to know me, that I'm not left alone by myself." And then this volunteer saying, "I was in a position to give and help and take something from the other person. It was an equal relationship. I cannot say a friend because it is too early, but I also shared some of my difficulties. And he helped me and told me one time, 'Oh, you're very clever. You speak 2 languages.'" So you can see here, which is quite interesting, sometimes there is this perception, which in some extent, it can be true, that these relationships are asymmetrical, but they don't necessarily need to be asymmetrical. And you can see here that with time, there was a degree of symmetry, and even the patient was, like encouraging and supporting these volunteers. So these are like 2 people that are in contact, and there's the potential to support one another, even if, of course, one is a vulnerable adult and has a mental illness, but it has the capacity and the potential to share their time and also be in contact and support someone who is a volunteer. So to conclude, as you have seen, it is feasible to remotely connect patients with psychosis with volunteers, even if they are very, very far apart. And for example, in this study, we had some volunteers from, let's say, Oxford or cities that are quite far from London. And it was possible for people to engage in a social contact and in a relationship, even if they were not in the same city. So there's quite a lot of potential with this. It was safe. There was no serious adverse event. we study, and participants seem to enjoy it and benefit from it. And so I think there is a room to explore this further in other contexts, and even maybe possibly with people from different countries or large differences, so that we can use the resources that are in the community, and particularly medical students who will be at, or they might choose another specialty, but from a view of supporting the population and the communities, there is this resource that has been studied in the UK. So there are many associations and many people that I need to thank, because without their support and their funding, this project wouldn't even be possible to be conducted. But by saying that I know sometimes times are difficult, but just to conclude, keep calm and volunteer. And if you have any questions, I'm very happy to be contacted at any time.
Thank you very much. And could you also please stop sharing? Yeah. Now, as you all see, we have another guest among us, but before going to ask him his comments, may I just quickly ask Ramin, Joyce, and Sevde if they have some comments or questions, because we will have our senior guest, Dr. Sartorius, with us for his evaluation or comments. Ramin, may we start with you, please?
Yeah, sure, Doctor. Yeah, I actually have a couple of questions, but I think I will start with asking Dr. Rodrigo first. If that's all right. Yeah, so with regards to the Population Health Initiative Week, did I get that right? Yeah. I was just curious if...
Yeah. Oh, no, sorry, I interrupted you. Please go for it.
Oh, what are some of the topics or initiatives or strategies that some of the students came up with that were taken up by the agencies in your community? I was just curious about that.
Oh my goodness. As you probably may remember, there are about 26 groups per year. And the one that I remember was something related to dementia, actually, that was taken on board by people. But I cannot remember exactly the strategy. I do remember though thinking at the end of the presentation, wow, this is amazing. And it was something simple. The one I can remember, because I facilitated the group, it was around childhood injuries. And there was this idea, I can't remember if it was adopted by a community agency, but just to show you an example of the type of ideas that students come up with. It was around how to ensure that a place is child friendly. So when people posted their homes for renting in this social media app or this site, they could add to it a little sticker on the side that would have like a tick, a little figurine of a small baby or something, a little tick that would indicate that the house has been explored and adapted to certain standards of the government, and it was approved as child-friendly. And something as minimal as that would have had a tremendous impact on diminishing childhood injuries. So that's the type of ideas that students come up with during that week. Yeah.
Thank you for the reply, and thank you for the question. May we go to Joyce for her comment, and if she has any questions to ask.
Yes, very nice presentation from all of you doctors. I got some very great insights from each one of you. I do have a question for Dr. Habdagan. Sorry if I pronounce your name wrong.
No, totally correct, thank you.
So it's about the one-sided mirror that the student can look at the consultation from the other side of the room. I was just wondering, how is that comparing to just a group of students standing next to a pair, like a consultation without the mirror? So how is the difference?
Thank you. Next question. I'd like to explain that. The purpose of that mirror is to make the patient feel comfortable. He or she doesn't feel talking in front of many people. She or he only sees the physician or psychiatrist who is interviewing him or her. So the interview goes in a more natural setting, but also we can observe the interview and see the patient, see the physician, hear them. So this is the purpose of that mirror.
But I
Can
think,
I have?
yeah.
Sorry, just a follow-up question. So, would the patient know that he's been watched from the other side of the mirror?
Yeah, sure. We take an informed consent first. He or she does know that the interview is being watched.
Okay, thank you.
And may I add one thing, Jenan? During the same implementation which we had, we would at the end take the person, and if there is a family of him, to the place where we watch the session, and he or she or the people who are watched can see the other people. Of course, it's not very natural during the session, but anyway, by video recording, and especially the way Eugene does, it's much, much better, I suppose. Thank you for the question, Joyce. And may we go to Sevde for her comment or question?
Yes. I'd just like to start that by thanking everyone for their slides, because they were I also gained a lot of insights. And I have questions, but I guess the one I'm most curious about is to Dr. Mariana Pinto da Costa, if I'm pronouncing that correctly. So in your research, you've mentioned how the patients have, in an interaction, patients and volunteers had different responses in terms of social comparison. So patients had less social comparison and volunteers had more. And I just think this is, I think, a significant result from the research. And I just couldn't understand why that could be and what that actually means.
Yeah, no, thank you so much for your question. So first of all, maybe a bit of more context. So the scale used was the social comparison scale. And so the social comparison scale assesses a number of aspects in which one can rank themselves in comparison to other people. So this would be, for example, in terms of feeling inferior or superior or more attractive or less attractive or more talented or less talented. So it has like a Likert scale. So for those of you who don't know, it's there's a statement and there is a ranking, and then people decide where towards more one side or towards the other. And so basically this scale was used both for patients and for volunteers. And well, one of the potential interpretations about these findings. So first of all, just a small remark that I didn't mention, but I should. This is a small feasibility study with 36 participants. So this had like 18 patients and 80 volunteers. And feasibility studies, they're normally initial stage after one develops, for example, an intervention or a psychosocial intervention, as this was, and they intend to assess two things. first, if the intervention is feasible at all. Like it could have been that it didn't work. People after 1 or 2 weeks got, bored, and no one would complete the intervention until the 12 weeks. And if that was the case, then would conclude that the intervention as it was proposed, it wasn't feasible and acceptable. So that's the number one. And then the number two, in feasibility studies like the one that I conducted, they are looking to see whether a larger study, which we normally call like randomized control trial, that normally looks into things that we call effectiveness, which means that does it work? So if such a study would be possible, and if the study procedures would be possible. Now, when we speak about study procedures, we're looking into things if it's possible to recruit. So for example, like if one would promote the study and no one wanted to take part, or if it took, let's say, 10 years, it would never happen because the study would finish before. But if it would take a very, very, very long time to recruit the target sample, then there would be a problem with recruitment. Or the other thing that we look is what we call retention. And retention means the number of people that drop out. So for example, it could have been that it was possible to recruit everyone and everyone wanted to take part in the study, but then after 1 or 2 weeks, people drop out or they disappeared and they didn't complete the end of study interview. So then there would be a problem with retention. Now, the other thing that feasibility studies look into, which is still a study procedure, is the outcome measures. Now, the outcome measures are the scales that are used, and the social comparison scale is one of them. And one of the things that we look when we are doing like feasibility study is if the outcome measures are feasible. So we look into to see if participants understand the question. So for example, it could have been that normally when a new scale is used, that either, and it wasn't validated, for example, in a specific population, then participants might not understand what the questions are. And so it creates issues of using that scale. Or the other way we have to assess that is the number of missing data. So if we have a scale and many people don't answer some questions, then it creates issues. Now, I didn't mention anything in my presentation, but the amount of missing data that we had was really, really, really low. And actually, there was absolutely no issue with the scale in particular. Now, responding specifically to the question that you asked, I want to say that what I reported was means. And in research means, sorry for the repetition of the word, but the meaning is that it's an average, right? So in another example, I eat 1 chicken and you didn't eat any chicken. And on average, each of us ate half a chicken, but I'm full and you're hungry, okay? So what I want to say is that what I reported was the average, so the mean of the social comparison scales of the group in the beginning and at the end. So I didn't report, like person to person comparison in the beginning and in the end. Now, speaking as a group, it could be that one potential explanation would be that people with psychosis, they are isolated, and by having this intervention, they are in contact with another person in the volunteer, in the community, a volunteer, and they know more about this person, and they hear that maybe they are more active and maybe they do a number of other things that they don't do. And because by raising awareness that other people can do other things, then it might explain potentially why these results were like this. And the same for the volunteers, but for the volunteers, this was reported in the interviews. Many of them said that they had absolutely no idea that struggles that people.
Mariana, I'm very sorry.
Sorry. I'm sure I covered the response fully.
I can understand you have a lot to share. Could you just cover it?
I think I did. Thank you. Yeah. Unless Sevdid wants to ask anything else, but I think I went very much in detail. Sorry, as you can see, I'm quite passionate, so I will stop here.
I know all of your presentations were so impressive, so nice, and we must have, maybe we could have only one of you for a long session. Now, I would also like to have each of our speakers to ask questions to each other if they have. But before going to that, would you allow me to give the floor to Dr. Sartorius, who has been watching at least some of our discussion, I understand. What would you like to say, Dr. Sartorius? Thank you for being with us.
I joined you because I admire what you're doing. I think it's a wonderful idea to do this on YouTube, allow people a wide attendance. I think and you get these outstanding participants, both the young ones and the less young ones. And I think that is really to be congratulated. Now, as I was listening, I listened to a little bit of what the last three speakers spoke about. And I had a comment for each, just for you to consider, among others. The first one was I just arrived at a time when the mirror was mentioned. And I was wanting to ask, I don't know, it was, I think it was...
Janan.
Yes, it was Janan. I was asking whether, in fact, he is also interviewing patients with cardiovascular problems behind the mirror and patients with dermatological problems behind the mirror. Why is it that he has to hide psychiatric patients from others? How can you discuss one problem? Are you not inserting at that point a stigma yourself? The psychiatric patient is so dangerous and so sensitive, you cannot speak to him unless you are a great specialist. So put him behind the mirror, and there, for the normal patients, of course, you can be present. You can talk to patients. You can be present when they are interviewed, when they are diagnosed, but not to the psychiatric. So I think it illustrates our sometimes error of separating psychiatry from general medicine ourselves. And we do it in various ways, in the ways in which we are teaching, the ways when we are teaching it. And I think it's something that we should become aware of. I think that one should either see all the patients behind the mirror or none of them. And if people don't like to be seen by others, then you will have nobody on the other side of the mirror, whether they are psychiatric or cardiovascular. And I think that's something that, in my opinion, I took this example because to me it's a symbolic one of many separations that we do early in the education of medical students, in somehow teach them that this is a separate discipline, has nothing to do with us. Now, I also then listened to Fran Bessler about the work, and I wanted to remind her that in the 1960s, WHO has recommended that the word psychosomatic should never be used, and that the word psychosomatic medicine is a complete nonsense. And the justification for that was to say that if there is psychosomatic medicine, then there must be medicine in which there is no psycho. That is, there are some diseases which are only physical. There is no psychological component in them. And of course, that is not the message which we want to do. All diseases are psychosomatic. Constipation makes you sad. And all sorts of physical illnesses make you feel in a certain way. And it's the totality of the human being which reacts to a disease in physical science, in physical damage, and in mental science. And I think it's something that, to my great surprise, the German society and the German specialists have put forward as being a psychosomatic. In other countries, there's also psychosomatic specialization. And I always regret that it exists because I think that the psychosomatic should infect everybody with the notion that each disease has psychological, somatic components, personality, all of this being together. And to understand an illness and to understand and help a patient, we should think about all of these factors in each instance, and not only when we meet somebody who happens to have asthma or has some other condition in which the social, psychological, and mental and physical factors are all more prominent. Then I have another comment, which I thought might be of, I was interested in the word micro-teaching, because that is something that I have not encountered before. But I think that the notion that we should train people in skills, as is obviously done with this, should really be placed very high, because these skills, which were mentioned by Dr. Bessler, I think are of tremendous importance in daily life, not only to examine patients better, but also to make your career better. Because if you learn how to speak to patients, you will also learn how to speak better to your boss and how to speak better to people who are influential and how to communicate to others in a manner that will be convincing. If you don't know how to do it, the patients will not get better. If you don't know how to do it, you will not progress either. So it's a skill that is universally helpful and something that I'm delighted to hear that you are teaching. Now, I think there was a wonderful example to me as well in the question of when and how do you consult students about what they want. And what we normally see is that people are not, they are introducing changes into training, remembering their own time as students. I remember when I was a student, this, that, and the other wasn't good, so I'm going to change it in my training. But remember, when you do this, you're already obsolete because you're already not a student any longer. The new generation is different. They have other thoughts. And we really listen to ourselves being young. And that is usually, for me particularly, but for other people as well, it's quite a few years back. So I think that the real way of teaching in a manner that is interesting must be done by a permanent consultation of those who listen and who are students. One has to listen to them, although sometimes what they say sounds stupid, it's not. It is something that they consider important, and therefore we have to tune in into that one and teach in that manner. Then I wanted to, Mariana Pinto da Costa is I think think very highly of her in many ways, but one of the features that I wanted to draw your attention to is her effort, a successful effort to be up to date with technology, to use things in technological manner when she speaks. And I think that today's technology is something that will open the door to the world. And unless you are really up to date with that one, I mean, she's the only one who used the transcript at the bottom so that people who do not speak English terribly well can understand it. She's the only one who thought about the fact that she should have a blurred background when she speaks so as not to detract attention. She was the only one who thought about the lighting at the right time. She also tested undoubtedly the strengths of her talk and a microphone so as not to be too, etc. And I think it's that carefulness to detail and exercise and really an effort to master modern technology, which is of tremendous importance in teaching, but also for other things that you might be doing in life. I know that all of you are masters in technological. I just spent about 15 minutes while Dr. Choshkun was trying to make me come into this group, which is, you know, my skills are minimal. So I admire them much more because of that as well. Now, one other last comment, maybe it is the way in which the very thing which you have done here could be made more popular. Professor Choshkun has mentioned that it will be known to the WPA sections, two of them, I think, and that is, but I would really urge you to continue in the same way and make this mixed bag of very young people, people middle in their career, people who are a little bit higher, make this discussion a normal part of a regular event, so to say, not very long, maybe 15, 20 minutes at a time, discussing modern things. And I would put it then on the WPA website and also make it available as a permanent resource for people who would like to listen. Something that I would suggest to Dr. Choshkun, who I know is an enthusiast of modern ways of communication and who might be driven to such a effort, because it's difficult to make it, but once you have it, I think many people would learn a great deal. So this is what I wanted to say, but I also want to congratulate you all to what you are saying and the ways in which you are doing things.
Thank you very much. Indeed, your comments are very valuable for us, for all of us, of course. Our friends, I regret you haven't followed Rodrigo and Eugene. Maybe you could do that through YouTube and you could share your comments with us separately. I really would like to have more sessions with many other colleagues contributing to this. Let me read a note sent by Professor Deva. He says, thanks for good presentation to Dr. Cenan. Stigma will be much less if psychiatry is introduced in year 1 of medical or nursing course, as stress management, not mental health or psychiatry, and gradually done yearly as behavioral aspects of cardiovascular, gastrointestinal, and etc., focusing on stress, smoking, obesity, etc. And 75% on primary healthcare stress management in year 4 and 6, and openly 25% on psychosis. He reminds us that we might use the words stress management instead of psychiatry or mental health. Maybe in a way similar to what Dr. Sartorius says, although I personally have some hesitations about this, but I don't want to take too much time. May I, please, I think you are going to say something, Dr. Sartorius.
Well, I think I agree with, of course, with Professor Deva for a long time already. But the point really, which I was trying to make, is that we should understand two things. Number one, psychiatry is not simple. And the notion that anybody can do psychiatry is wrong. But there are many techniques within psychiatry and many problems which are psychological, which must be the common property of anybody who has a medical degree. And it's the difference between the psychiatrist and the general practitioner is the same as the difference between a cardiologist and the general practitioner. It's not that we are a separate discipline somewhere over there, and therefore we can teach general practitioners. No, we should teach the general medical student as much about psychiatry as a cardiologist teaches them about cardiology. And I think that also means that our training for many of the things has to be done not in the psychiatric department. It's the anxiety, preoperative anxiety must be, the ways in which you deal with preoperative anxiety must be taught in the department of cardiology or in the department of surgery, because that's where patients are. And that's where somebody will have to deal with this later on, being a surgeon or being something else. And it's that difference which I think is important.
Yeah. Before, now we have come to the end, but before closing, may I ask in the same order for their last comments or assessments to my dear colleagues. Rodrigo, may we start with you, please?
Well, simply to thank you again, Bulent, and to thank the medical students who are with us, and thank you very much for being here, and to my colleagues and Dr. Sartorius for the presentations and their comments, and to everybody who is looking at this through YouTube. Thank you for attending. It has been my pleasure. I knew it already, but it's great to see all the great work that my colleagues are doing, introducing medical students with to notions around mental health, and ensuring there are, in using these creative ways of improving people's mental health and well-being around the world. It's great to see that this is a global effort, and yeah, thank you very much, everyone.
Many thanks to you, Rodrigo. May I just go to Eugene? Could you say a few words, please?
Thank you again for inviting me here to have these sharing sessions and all this. I did learn a lot from a lot of the things that everyone else talk about. It sure is very different from how I would approach education over in my region. But it's been a great experience, and thank you for the feedbacks from everyone also. It's also part and parcel of the learning experience. Yeah.
Thanks a lot, Eugene. We really have a lot to learn from each other, indeed. And Cenan, what would you like to say?
I would like to thank you again, Professor Coşkun, and all my colleagues and students, and Professor Sartorius. I am once again very excited to see Professor Sartorius with us, and I find myself very lucky to get feedback from him. And once again, Professor Sartorius make me gain some insight. I have never thought that it would be a part of stigma, that mirror room, but I can answer this question. I would prefer, when a cardiologist or internal medicine was examining me, I would prefer that mirror, because it's as Joyce asked me, the patient already knows that he or she is being watched. It's not a hidden thing, but it's the purpose is instead of being directly in front of physician's eyes in the same room for 45 minutes, maybe we can, we think that he or she can feel some more comfortable. So I think the same inconvenience, and if this was a cardiology examination in one room, 30 students, lecturers, residents also would bother the patient. So I never thought that it was a part of stigma, but I think maybe you are right.
Together.
Thank you. Thank you. When I said I had some hesitations, I would like to mention a few things like that. Maybe we could just make a session on stigma, and we could spend much more time on that. Yeah, please, Francisca, may we listen to your words?
Well, I just wanted to add something to Professor Turia's and to Shannon's comment about we are used to listen to our patients, and we are also used to talk about our patients with our colleagues in absence of them. And there is an approach, and you might want to try that one day. And there's this approach that you invite a patient to listen when you talk with another professional about this patient. And what you might observe at this point is that you change your wording, you change your attitude, and I think you experience your patient more as a human being that's connected to you. So this would be one suggestion I would give to this to us. And the other thing I wanted to add is, Bulent, you were asking about how to assess all those communication skills and stuff like that. Just want to briefly say that I think that objective structural clinical examinations are a good way to do that, to see and to observe medical students, how they act in daily life and when they're under pressure, and to help them to give feedback. Finally, I'd like to thank you very much. I'm very, very happy to see all of you here. It's my privilege to be with you, and special thanks to Bulent, of course, for all his efforts. And I wish you all good health.
Thanks a lot, Francisca. And for her last words, may I go to Mariana, please?
Well, first of all, thank you so much, Professor Bulent Koskan, for organizing this event. And thank you, Professor Sartorius, for providing feedback to all of us. It has been a great pleasure to hear everyone's presentations and actually to learn from each other on how different people in different parts of the world are being so creative and using local resources to promote mental health and to support medical students to psychiatry. So I really hope that such initiatives are repeated, and I wish you all the best for the future.
Thanks a lot once more. And a few words from our youngest colleagues. Ramin, may we start with you again?
Yeah, thank you so much, Professor Bulent, for giving me this opportunity to be a part of this. And yeah, I think the discussions that we've had today really raise an important question that we need to think about, and that is how we teach psychiatry to medical students and how we are going to normalize mental illness and reduce the stigma to mental illness. So I think, yeah, like everyone mentioned previously, it's definitely a very insightful discussion that we've had today. And I think it's something we can take back and reflect more on. So yeah, thank you so much, everyone, for your great speeches.
Thanks a lot. Yes, Joyce, now your turn.
Thank you, Dr. Bullen, for inviting me. And I enjoyed everyone's speeches and the great discussion. And even though I'm still a medical student, but hearing the different interventions that you guys provide for a medical student also give me insight about what kind of healthcare professional I want to be in the future. So it's really inspirational for me. And yes, thank you all.
Again, thanks for your last words. Sevde, would you like to say a few words as well?
I'd like to thank you, Dr. Blunt, for giving me this lovely opportunity and for every single speaker here. I agree with everyone else. I mean, as a medical student, this really helped me analyze what I'm being taught about communication, generally to patients, not just for psychiatry, but for every area. I think it's very valuable to work on this and to think about it and try to improve it. So yes, thank you all. And I'll see you again.
Well, I'm afraid time goes quickly. I would like to say very few things as well. Inviting people is very hard indeed. Whom we should invite and why is the hardest question, especially for the students. It was, of course, they just represent some of the students, and I wish we would have a general overall group to come together in a routine way. I hope we can do that, and we have an opportunity for trying such a thing on the World Mental Health Day. Actually, we are planning to have a large meeting starting from different time zones. Maybe we could start from which is fine for the eastern part, and we'll go to the western part. And when we are at the eastern part, we are also able to have our colleagues from Americas, although they are one day later. Anyway, we will try such an activity on 10th of October, World Mental Health Day. And I would also like to touch one point which Dr. Sartorius made about psychosomatics that reminded me when he had said there is no social psychiatry because all psychiatry is social, and there is no psychosomatic medicine because it can't be separated like that. But still, and even what Cenan said, when we discuss in a coming meeting the stigma issue, we could maybe discuss on what psychiatry is, what mental health is, what medicine is, and we haven't been able to invite other mental health workers yet. Our plan in WPA section on psychiatry, medicine, and primary care is to invite other students from other health, mental health disciplines in the coming time, I hope soon. And last suggestion he made, Dr. Sartorius made, was putting these on WPA's webpage. Dr. Afzal had promised to do something like that. I hope he will. And if Dr. Sartorius, we can refer to Dr. Sartorius, he would take that into consideration more, I suppose. And before ending, with the permission of all my dear colleagues, I would ask Dr. Sartorius for his last words. Please, Dr. Sartorius.
The English word last is very often not the best one. Last means you will never speak again. It is really the most recent, shall we say, or another comment or something that I would prefer. I would like to make more comments, not that this shouldn't be the last when we are together. So I'm very intrigued by what we have just heard. And I think that the Chenal's realization about the way in which our behavior is read by others is very important. And I think that what he said that he might wish to try to do would be to interview cardiovascular patients behind the mirror. It would be also a good idea to equalize, so to say, because there may be people with cardiovascular illness who do not want to be discussed in front of everybody. It's the same principle, which they want to be secretive as well. But I want to congratulate you on the notion to do something about stigma. And if you do it, I think it would be helpful to have, in addition to the excellent people whom you might invite from our field, also a surgeon who would come along, and maybe some other specialist who thinks that psychiatry is garbage, as well as some of the psychiatrists who feel that surgeons are garbage, because the link is from both sides to be established. The psychiatrists are sort of withdrawing into their self, and they are not wanting, they say that others don't accept them, but at the same time, they make very few efforts to do it. So if you do a stigma, particularly creation of thinking about stigma that the medical profession produces, in addition to what the society produces, would be helpful to have various representatives with us as well. And I was very pleased to be invited here today. I think I enjoyed the presentation greatly, and I only regret that we don't have more time now to go and have a glass of wine or a beer or a coffee or whichever else you might wish to drink and talk further. But with God's help, maybe there will be opportunities to us to meet in reality, not in a two-dimensional space. Thank you very much for inviting me. And thank you all for what you have said.
I still have lots to say, but we have to end. Thank you very much for your contributions, and thanks to those who have watched. They are not too many, but I believe it will be a resource for future. Hope to meet in another meeting, and maybe on the 10th of October 21. Bye for now.